So we're going to assess the wrist, some of the hand, and the elbow. We're going to go through a sequence of palpations that'll give us a lot of information in a relatively short amount of time. So this is, again, choreographed in a specific way. So just open your stance up a little bit so you're just comfortable. Right, let your arm relax. Turn this way a little bit with your feet as well. Square off. Good. So the doctor is going to stand perpendicular to their patient, and the arm's going to be relaxed and held in this manner. Right? The first contact is a thumb-index web on the distal radius and ulna. The second contact is the pinky in the patient's thumb-index web, which allows you to control the position of the wrist. Right? And you want the wrist in a little bit of extension to perform this palpation. So again, my first contact's on the distal radius and ulna, and I use the other thumb-index web to grasp the proximal row while I maintain a little bit of wrist extension. Comfortable, my patient's relaxed. I stabilize with the proximal hand, and I move the proximal row A to P and P to A on the distal row. So there's my palpation right there. Right. Then I'll move this whole thing down a little bit. So now this is on the proximal row. I still maintain my wrist control. And now I'm on the distal row with my other thumb-index web. And I perform the same palpation. Right. This is often hypermobile. Most patients will be hypermobile in their mid-carpals. If I do pick up a restriction, what I can do is palpate the carpals individually. All right. So I'll come back to my original contact, which is right there on the distal radius and ulna. I still maintain control of the wrist with my pinky and the thumb-index web, but now I use my thumb and my index finger to pinch the individual carpals. So I'll grab the scaphoid and I'll push it back and forth. I'll move over to the lunate and I'll push back and forth. I'll go over to the trapezoid and I'll push it back and forth. I'll go over to the trapezium and I'll push it back and forth. I'll go over to the hamate and so on. I'll push it back and forth. And that'll give me an indication of whether there's any individual A to P restrictions. If I feel hypermobility generally throughout the carpals, I probably would skip that step. Right? But when I pick up a restriction the first way, I'll go in and I'll palpate them individually. The next part of this is actually it's not really a dance because the patient doesn't have to do anything. The doctor does all the moves. But if you were to think of this as a dance, it would look like this. I just wanted to get that on camera. Right? So the patient's back is to you, right? Right? And what we're going to do, I'm actually going to do this side so the camera can see it better. Right? So what I'm going to do is I'm going to capture the patient's arm in my arm. Right? And boy, those nails do look good. And perfect. You're welcome. And we're going to hold the thumb out just to keep it lined up with the radius, right? And what I want to do is check long y-axis of the scaphoid, the trapezoid, trapezium, and the thumb itself, right? So it's long y-axis, it's pushing it away from me, right? Here's the motion, doctors. It might be new to some of you. It's a motion you want to learn how to do. It's very helpful in treating and assessing and actually manipulating the extremities. It's this motion. It's this motion right here. You're pushing out with your thumb as you pull back with your digits. Now, when I was a kid, I had an opportunity to work on a dairy farm, and this is why I know this, all right? It's like milking a cow, right? It's that motion where you kind of come down on the cow to get that milk out, right? All right, so here's what it looks like. All right, my thumb's on the scaphoid, and I push the scaphoid away. Right, my thumb then moves over to the trapezoid, which is at the base of the second metacarpal. It just moves over a little bit to the trapezoid, and I push the trapezoid away. Then I go over to the base of the first metacarpal, which is the trapezium, and I push the trapezium away. I milk it away, so to speak. And then I put my thumb on the base of the patient's first metacarpal, and again I push. Right. So if I were to do it all at once, it would be scaphoid, scaphoid, zoid, zum, thumb, right? Scaphoid, zoid, zum, thumb. And they're all right next to each other. You're in a very small area, all right? After that part, you turn, and now you're talking to the hand, right? So you're looking at your patient's hand. What you're going to do is, I think the camera will be able to see this. You're going to take your fingers and you're going to place them in between the distal radius and ulna so that your thenar is on the patient's radius. So you've captured the radius and you place the ends of your digits between the distal radius and ulna, right? Now, if you have long nails, it will get in the way when you try and do this. So the next part of this, what we're checking now is the ability of the distal radius and ulna, the ability of it to be able to spread apart. This is a very common restriction in the wrist area, and it can contribute to that hypermobility we see a lot in our patients, and in ourselves as chiropractors. We tend to develop this ourselves. So what we're going to do is we're going to hold on to the radius with our fingers in between the distal radius and ulna. Then we take our other hand, our other thenar, and if I start to push that ulna forward, it'll start to push my fingers in between the distal radius and ulna. And then what I'll do, I'm just turning this so the camera can see it, I'll wrap my fingers around my other fingers, right? And from here, all I have to do is squeeze. I don't have to push back and forth. I just squeeze to see if I get a little separation in there. You're actually, I can feel it move a little bit, but there's some stiffness in there, which is very common. The next movement is the A to P and P to A movement of the ulnomeniscotriquetral complex. So from this same position, I just let the wrist fall, and with my thumb and the rest of my fingers, I grab onto the distal ulna, right? Then I take my thumb index of the other hand, and I go right above that to grasp onto that ulnomeniscotriquetral complex. And once I've squeezed it between my digits, I can push it back and forth to see if there's some nice anterior to posterior or posterior to anterior glide. Back and forth just like that. All right. From there, I turn the palm so I'm looking up at it. Right? And what I do is I place my thenar on the hypothenar and my other thenar on the patient's thenar. And I maintain a little bit, relax the elbow, maintain a little bit of wrist extension, and I'm checking the pliability of the flexor retinaculum as I gently pull it apart. When patients are tight here, this will generally feel really, really good, right? So you're just checking the flexibility of that flexor retinaculum, transverse carpal ligament area, like that. From there, what I do is I come over to here to check the elbow, but I'm going to do this on the other side so the camera can see what I'm doing. I'm going to roll this up a little bit. So you step back to your original starting position, right? Relax this. And with the thumb up in the air, that's going to mean that the forearm's halfway between supination and pronation. And look at what the elbow does. Look at the carriage of the elbow. Is it fully extended? Is it hyperextended? And check the end feel. What should the end feel be at the elbow? It should be bony. It should be a hard end feel. If you feel a softer end feel, or kind of a giving end feel, that's not normal. That represents a loss of extension. So that's what you're checking for, a loss of extension at the elbow. Sometimes a loss of extension can be due to short forearm flexors, which is very common because of our flexor dominance. So we can check to see if the forearm flexors are short while we're here. What we'll do is we'll take the forearm and we'll supinate it. We'll grab onto the patient's hand like in a handshake. We'll let the elbow bend. We'll fully extend the wrist and supinate the forearm, and then retry extension. If the forearm flexors are short, we'll see an additional loss of extension there and a loss of that nice bony end feel that we should encounter. The last thing we will do is check for supination at the elbow. I'm going to put my thumb on top of the radius. My thumb's on top of the radius. My fingers, if you can just turn this way so the camera can see it, my fingers are underneath the elbow. I'll come back to your starting position. So I'm supporting the elbow with my fingers underneath, my thumbs on top. My other hand grasps the lower distal portion of the forearm above the wrist. So I'm at the radius and ulna. With both hands, I'm going to be multitasking here. With both hands, I'm going to extend the elbow. I'm also going to be using both hands to supinate. So I'm supinating here, and I'm supinating with my contact on top of the radius. And I'm trying to appreciate what that end feel is like. So here it is when I put it all together. And there should be some give there. And if it's restricted, you'll often see the patient wince a little bit. If it's real uncomfortable, you'll sense that they don't like it. They might even raise their shoulder up to get away from you doing it, which you don't have. And I can feel some nice give there as I perform that coupled motion together. Okay? And that's our wrist, hand, and elbow assessment.